everyone. We're going to go ahead and get started. My name is Melanie Mock. I'm with the Kentucky Hospital Association. We also have Emily Henderson, Carla Donnell, and Claire Arendt in the room. We also have Dr. Doug Euler on the webinar portion today. We are going to go over the Kentucky SOS data metrics today. We are recording the call, so again, we ask that you place your phones on mute by hitting *6 or the mute button on your phone. This call will be available on our website by the end of the week, along with a copy of the presentation and a copy of the EOL. At this point in time, you can click on the third icon at the top right hand of your screen, which says Media Library. Go to Shared Files, and you can download a copy of both the presentation and the EOL. If you have any technical difficulties during the webinar, please feel free to email me at moch@kyha.com. At this time, I'm going to go ahead and turn it over to Dr. Euler, who's going to start our presentation. And at this time, Doug, you can go ahead and take over moderator.
Okay, hopefully everybody can hear me. So thanks for taking some time to listen to this. I'm going to go through the first portion of some of the metrics and a little more deep dive into those as we go, and then to kind of wrap up towards the end, Melanie's going to discuss a little more on the reporting, physical reporting through Kentucky Quality Counts. So just kind of a general outline of what what I'm going to try to talk about today. Again, just a really high level standards overview for just to kind of put all this in context. That's really going to be a rehash of what we had in the in-person session. So we got like one slide dedicated to that. But then we're going to spend the bulk of the time is kind of diving a little bit deeper into the metrics associated with standards 2, 3, and 4, so the kind of outcomes measures that we discussed at some of these in-person sessions. And the way that I've kind of set this up is that there's 3 to occasionally, as we get into metric number 4 slides dedicated to each of the metrics here. And the first is kind of the overview of this and the stuff that's in the explanation of the measures document that hopefully everybody's had at least a chance to kind of skim through some. So that's the first slide. The second is honestly from my non-data mind, but as I've talked with some of the data folks at Kentucky around this, kind of our suggested methodology for how you might think about trying to pull this information. And then with each of the metrics, I want to open up for questions, comments, what feedback you guys have, even potentially some anticipated problems and stuff that we may not have thought of. So we'll do that for each of the metrics and do that as we go. So 2A, we'll get through that one and then do all the same thing for 2B, 3A, B, C, 4A, and B. And then again, as I mentioned before, Melanie will talk a little bit at the end about the actual reporting structure. So the general overview, remember there were 8 standards. 3 of those standards were associated with some kind of outcome measure. So what we have here really are 3 standards and 7 associated metrics from that that we're going to spend a little bit more, or we're going to spend the bulk of the time talking about here. So one is the kind of safe opioid prescribing and safe opioid use within the institution. So that's within 2A and 2B. 3A, B, and C is opioid use in the emergency department. And then 4A and B is opioid use for some select procedures. So into some more detail here. So when we look at metric 2A, the first of these, this is one of the 2 metrics that was taken from some of the CMS proposed measures in the coming years. So what this metric basically is looking at naloxone administration for reversal of an opioid that was administered by the institution. So the numerator within this are adults only, so 18 years or older at the time of admission. That's all of these measures. It's always adults. Admissions, including inpatient and ED and observation stays, that had documentation of intravenous naloxone administration or potentially doxapram. I imagine it's going to be substantially less common, but intravenous naloxone administration within 24 hours of having received an opioid. So they got a naloxone at your institution and you had given them an opioid before they came in. So this isn't necessarily the people that overdosed and came into the ED and needed reversal. There is the exclusion that was pulled from CMS as well, as if this was administered during or within 2 hours following a procedure. So probably using kind of timestamps and locations for OR bookings and that sort of thing is likely the best way to identify that. That's what we've done, is looked at timestamps for OR bookings and saying if it happens within this time period, plus 2 hours at the end, to exclude the naloxone cases there. And then the denominator are discharges of all patients occurring in the past 1 month observation period without exclusions. So as, again, I kind of thought through this, and we kind of thought through this, first looking at identifying the admissions, so including the ED and observation stays for the time period, and that becomes your denominator. Then identifying the patients who received IV naloxone or doxapram based on medication administration, and in all likelihood is probably going to be more accurate than automated dispensing cabinet polls for the drug. So we personally identified ours based on documented administration in the MAR. And then excluding the patients who didn't receive an opioid within 24 hours before that, and excluding the patients who received the IV naloxone within 2 hours of a procedure. This one went a little quicker. I think the next one's maybe going to take a little more time, and some of the others may take a little more time as well. But I do want to open up what questions, comments, anything does anybody have around this metric at this point?
So you can ask questions in two forms. You can put it in the chat box, or you can unmute your line by hitting *6 or your mute button and asking the question directly to Dr. Euler. So again, you can chat your question in the chat box, or you can open your line by hitting *6 or unmuting to ask your question.
Can you hear me?
We can.
Okay, so I understand, Doug, I understand why. So first when you said ED admissions, that kind of concerned me, but I understand with if there's not an opioid administration prior to that, so that would exclude patients that come in already overdosed that we administer. It may be a little more difficult based on our systems to pull that information, so that may make it a little harder versus just excluding ED altogether. So it'd be interesting to hear others' thoughts on that. The other thing is we do track currently and have for a long time naloxone administrations related to our anesthesia services. Way back when, I think it was just a knee-jerk that anesthesia would give naloxone just to kind of hurry the process up and get them out the door, but we know that that is not best practice. Even their recommendations from the anesthesia white paper says that it shouldn't be given. So we still track, it's still patients that maybe were overly sedated or weren't monitored long enough. If we're still having to give naloxone, maybe out of the recovery area, but some of ours get to the floor fairly quickly. Is there any concern that we might miss some potential there?
Yeah, so in relation to the naloxone post-operatively, just to make sure I understand your question right, the question is we may miss the potential for an intervention if we're excluding patients who receive naloxone within 2 hours of a procedure?
Well, it's still an adverse drug reaction if you have to treat it, and we're treating it because we caused it, correct? I know they had a procedure, but then, looking at different patients, age, what have you, we've still had to reverse something there post-operatively that we caused. So we still count that as an ADR. In your metrics here, we would not be counting.
I see. Okay. So what I think we can do with this, so this was stuff that we had discussed before, because I think within the advisory group, I think with the specific post-operative components, I think there's also an added, that's an added step probably for some folks to find out a methodology to accurately exclude them that can probably be pretty tricky, I would imagine, at some institutions. So perhaps we can take this, Melanie, perhaps we can take this and discuss it a little more. The reason that it's in there now as an exclusion is because it's in as an exclusion in the proposed CMS metric, and our intent was to kind of get everybody ahead of the curve. So once CMS, if and when CMS requires that, we as a group are already ahead and ready and know kind of where we stand and have made some interventions. But it is possible that is going to introduce a bunch of extra barriers, and I agree with your point that is something still that we've caused, that especially with some supporting information, if that's not best practice, which I think is reasonable, then maybe we may remove that exclusion.
Our name is here before you.
Thank you.
All right, so Doug, I made a note for us to take that committee. There's a question in the chat box. Procedures.
Yes, I can.
So there's a question in the chat box. Are procedures with moderate sedation included in your definition of a procedure for this measure?
Up here.
Okay.
I see. So the way that we have, so the way that it's specified, or the way that it's described in the CMS measure is, it simply says procedure. We have looked at this as a procedure associated with an OR booking. So if it's a bedside, something like that, it would be included. I think that's another consideration and something that makes this a little more ambiguous, that if we bring that into the bigger discussion around should we include post-op, exclude post-op in general, that's something that we need to talk about when we talk about including or excluding that. Because I think if we lean towards excluding the post-op as excluding that or removing that sentence from this, that would address that component as well. I see there's another question about 24 hours of opioid administration, limit to administration by our hospital, let's see. Sorry, there's a line about withholding 24 hours of opioid administration, limit to administration by our hospital. If you can identify that, probably because, so this is in relation to Jackie's question, I would say probably, unless you have a reliable way that you can identify that it was administered by another, by a healthcare provider there. Was somebody trying to say something?
Yeah, and that goes, this is Jackie. So I think if we want to try to compare across all of the work, we do need to decide which we're going to do. And if some people can gather and others can't, then the data is not going to match and it won't be really comparable. And this kind of goes to that ED question that was asked earlier, because it gets tricky there. So I'd like us to come up with a standard on that so that we can actually compare to each other. Okay.
So we can clarify that. Yeah, I would say administration by your hospital. Yes. But I think we can clarify that some as well. Let's see, the other couple of questions in here, isn't that part of the AD opioid data and measuring something different? Melanie, does that read to you like asking about the current measure they report? I'm looking at Deb Campbell's question in the chat box.
Doug, this is Emily Henderson, and this definition actually differs just a little from our current HIN definition, and we discussed these at the regional training meetings, but this does differ just a bit from the current naloxone reporting of our HIN hospitals. Yes. It's not the same.
Okay. Yep.
Doug.
Okay, thank you. And then moderate sedation being included depend on the agent being used. I mean, essentially what we're, to Jill's question here, I'm not entirely sure that I understand that question. I think what this seems to be pointing towards is a discussion that is things to add into the discussion of what should we do about the if we're looking at naloxone administration. Sure. So yeah, and actually that's some things that we've identified internally as so some of that would be excluded if they hadn't received an opioid before. So if the only thing that they received was the Versed, then they received naloxone later on. That wouldn't be in here because they hadn't received an opioid. Now, if they received an opioid and Versed and they were just sedated and they didn't have respiratory sedation or respiratory depression or anything like that, that would still be counted because they would have received the opioid within 24 hours. What we've identified internally, even at UK looking at this, is there are cases where that happens, and then that becomes educational opportunities. Naloxone is for reversal of respiratory events, not necessarily for confusion, delirium, agitation, any of the other stuff that may happen. So I think where this is pointing is towards just really evaluating the post-op component here, which will add to the agenda. So, okay. Other questions and comments about 2A? Thank you, this is helpful.
Great. Thank you, Doug. Yeah, I think at this point, I'm going to go ahead and mute all the lines. We are still hearing some background noise. So at this point, all questions need to be in the chat box going forward. We will reopen the lines at the end of the call for any verbal discussion. But at this point, I'm going to mute all lines. Please put all your questions going forward in the chat box.
Presentation mode is now enabled.
Okay, so as we look at...
okay, Doug, you can move on to metrics.
Got it. All right, so we'll look at 2B here. So concurrent electronic prescribing. We've already got a couple of questions about this and some emails and other things. So what we're looking at here are patients that are prescribed electronically, so either e-prescribed or you electronically generated and printed out that prescription. So you have some record of that prescription being created and the actual prescription record in your electronic medical record. If it's a paper prescription only, there's really not a good way to try to track that. So what we're looking at here is really just electronically generated prescriptions, so either e-prescribed or generated in your EMR and printed out on a printer. 2 or more opioids at the same time, or an opioid and benzodiazepine at the same time at discharge from, again, the hospital encounter. So within the numerator, again, this is adult patients, 2 or more opioids concomitantly, or an opioid and benzodiazepine concomitantly at hospital discharge. The denominator, and this was the other metric that came from the proposed CMS metrics, the denominator here being adult patients that were prescribed either an opioid or a benzodiazepine at discharge. So you have all the patients that were prescribed an opioid or a benzodiazepine at discharge, and then from that, how many were prescribed either 2 opioids or concomitant opioid with a benzodiazepine when they left. I'm going to skip to the denominator exclusions briefly. So encounters for patients that have an active diagnosis of cancer during the encounter, and this would be identified using active cancer ICD codes. And note about ICD codes is if you guys are looking at this, and I imagine this is going to play a little more on metric 4, but I imagine there's probably going to be some kind of internal validation within your own systems as you look at this, and does this make sense? Does this seem right? That kind of thing. If you notice that you seem to be including or excluding the wrong populations, because your hospital identifies these differently, doesn't use the codes, doesn't use these codes, uses a different thing, please let us know that information so we can keep everything updated and make sure that, again, we're all reporting the same thing. So anyway, exclude patients with an ICD code for active cancer And exclude patients ordered for palliative care during the encounter. However, your institution identifies that. There's not a standard way, I think, that institutions are going to identify palliative or hospice care during the encounter. So that is going to be as identified by your institution. And then the length of stay greater than 180 days. The part about cancer is there are Z85 codes, as I understand, that would say a personal history of cancer. As that is not an active cancer, then you would still include them in the analysis. I'm going to address the question in just a second when we get to Suzanne's question in just a second when we get to the questions and answers about this specific metric. So the way that I would think through this is, again, identifying patients that were prescribed an opioid or a benzodiazepine. So that's a typo in the slide for this on number 1 here. This is an opioid or a benzodiazepine via electronic means during the reporting period. And then, so patients that were provided via paper, fax, et cetera, you can exclude those patients. Excluding patients with a length of stay over 120 days, excluding patients with those ICD codes, and excluding patients with a palliative or hospice consult during admission. Within number 1, you could actually just look at patients that were prescribed an opioid because they have to have an opioid and a benzodiazepine together to be included in the metric. So, but as we look at opioid and benzodiazepine to form that denominator. So then moving to so at the end of number 4, you have your denominator, and then at number 5, identifying patients with concomitant prescriptions that were electronically generated. So the question that we've got before is, well, if somebody's on a benzodiazepine when they come in and we write them for oxycodone, are they included in this numerator? And the answer to that is if you provided them a prescription, then yes. So if they came in and they're on benzodiazepines and you said, just keep taking your benzodiazepines, here's a prescription for the opioid, but you didn't write a new prescription for the benzodiazepine, you said keep taking your home stuff, that would not be included. If you said here's a refill on your benzodiazepine and at the same time here's a prescription for the oxycodone, then yes, you've provided them with concomitant prescriptions, and those would then be included on this. The same thing with 2 opioids. So if there are 2 prescriptions that were electronically generated and the patient left basically with 2 physical prescriptions for these drugs that were electronically generated, then they would be included. And you add those 2 together to generate the numerator. Okay, so the easy question here, the slides available for after the webinar for download. I think that you may be able to get them now. I think they're going to be. Oh, there we go. It's being addressed in the comments section. So the other question here from Suzanne, in the description, it speaks of a hospital-based encounter, and then the explanation is inpatient emergency and observation. Does it include outpatient surgical cases? So what we have looked at here is a hospital encounter being inpatient emergency or observation. So that would not include outpatient surgical cases. So the quick answer to that would be no. Are there other questions or comments about this metric? Okay. I don't see anybody trying to type anything either. So, okay. Well, I'll move to number 3. Sorry. Yes, so to clarify here, exclude them if both drugs were not prescribed, right? So if they only left for 1 prescription for something, but had the other one at home, then that would be excluded. If they left with 2 prescriptions, then you would include them. Okay. All right. I'll keep an eye on the chat box if other questions come up about that. Okay. So into 3. So metric 3 is essentially ED use of opioids for a couple of specific conditions, so ankle sprain, migraine, and renal colic. So what we're looking at here are patients who received no opioids prior to discharge from the emergency department. So these are only individuals that were discharged from the emergency department with, in this case, acute ankle sprain as identified by the S93.0, S93.4 ICD codes. So if they're admitted to the hospital for some reason, then they would not be included in this. These are only the patients that were seen in and discharged from the emergency department. So the simplest of those cases, if you will. And then the numerator is patients who did not receive any opioids prior to discharge after their initial encounter for ankle sprain here. The denominator, the denominator here is patients that were adult patients that were discharged from the emergency department after that initial encounter. Excluding patients that, so there is a 7th character modifier that you can put on these codes of a D or S that would say this is a subsequent encounter. So excluding those patients, so we're only looking at the initial encounter here. It looks like there is a question that's come up about, I believe this is from the last metric, only taking into consideration what is prescribed during the visit. Don't take into consideration if the patient was already on a prescribed. Yeah, so it's only for 2B, it's only the prescriptions, the prescriptions that were given to the patient when they left that visit. So kind of how I think through these and the methodology for these is the same for A, B, and C. It's just the ICD code. So identifying the patients that were discharged from the ED with that ICD code, excluding the modifier, that 7th character modifier. Identify patients, the way that we've done this is identify patients that received any opioid while they were in the emergency department. And then because the numerator is patients that didn't receive an opioid, so here we're looking at basically the higher the number, the better. Patients that didn't receive an opioid, you subtract that from your initial denominator there. So are there and B and C within number 3 are going to be very similar, just different ICD codes. But are there questions about these metrics or this specific metric? Okay. I'll go through B and C since they're almost the same. And if something comes up, I'll again keep an eye on the chat box here if something comes up specific to these. So metric 3B is the same as 3A. It's just a different ICD code, which is G43 for migraine. So again, patients who were discharged from the emergency department after an encounter for migraine. I do not believe that there is any kind of modifier that can be put on this to say this is recurrent or something like that. So their initial encounter for that migraine. So the methodology here would be the same, identifying the patients that were discharged from the ED with an ICD code for migraine, identify the patients that received an opioid, and subtract that to identify the patients that did not receive an opioid, or quantify the patients that did not receive an opioid. Metric 3C is the same, except for renal colic. So we're looking at ICD codes N20 through 23 with the exact same methodology here. So again, these are patients that are discharged from the emergency department with the ankle sprain as one metric, migraine as the second, and renal colic as the third, that did not receive an opioid while in the emergency department. Okay. So I haven't seen any questions come up about those ones. So again, the only thing that I would ask is, as you're looking through these within your institution, I feel pretty good about the ICD codes that are included here. They seem to make sense when we internally reviewed them based on our data, but if you notice, if you discover that this seems not to be identifying all the patients, if it's capturing patients that don't seem to match for whatever reason at your institution, please let us know. And if there is another way that your institution may identify these patients, please let us know that as well, and we can include it to make sure that, again, we're all capturing the same thing. Okay, so to Stephen's point then of migraine has more specific codes not to use G43, then yes, maybe we can got it. Maybe we can talk to Stephen of how else this is identified. So Melanie, I'll make a note of that.
I've done the same, Doug. And Stephen is, I'm going to put my email in the chat box. And so if you want to email me things that other codes that you are using, please feel free to do that.
And then, yeah, we'll stop on the slide ahead instead of the one that doesn't have any information on it. 2B, if they have one or the other, e-prescribed, yes. So for the denominator, one or the other, the numerator is prescriptions generated for both. So Tracy, that is correct, yes. And I'll note that is not what step one on that 2B said. So that's probably where that confusion comes from. So I'll make sure that gets that we fix that, because I think on there it just says opioid, but what Tracy has in her comment there is correct. Okay. So as we move into the last one here of 4, so essentially there are 10 procedures that are between 4A and 4B. The only difference with these is 4A is 3 days or less, and 4B is no opioid at all. So the procedures are different there. So what we're looking at in the numerator, patients age 18 and older undergoing that selected procedure that are prescribed, again, electronically, the same as we'd identified before, 3-day supply or less of a Schedule II opioid. So this is just in alignment with House Bill 333. So tramadol, codeine, buprenorphine, those kind of things that aren't Schedule II are not included in this. This is Schedule II opioids only. And then patients 18 and older undergoing the selected procedure. So again, there are 10 procedures between A and B. Ideally, we're all reporting as many as we can. All 10 is again ideal, so we can get the most comparisons and try to get better understandings of what a reasonable goal or benchmark or baseline or anything like that might be. So the more places that we can get that information from, the better. We're hoping for is at least 3 between 4A and 4B, unless you don't perform 3 total between 4A and 4B, and then obviously it's you have nothing to report there because you don't perform those procedures. So I'll say this is the same as with the ICD codes associated with number 3. These are based on CPT codes. If you identify that this is not complete, or there is something within this list that is capturing something else at your institution, please let us know that information. So these are the 3 days or less procedures. So appendectomy, arthroscopic partial meniscectomy, breast biopsies and lumpectomies, cholecystectomy, prostatectomy, thyroidectomy, and unilateral inguinal hernia repair. So again, as you're looking at these, specifically for if you look at meniscectomy or something, if there's one code in there, if there's something else, and this number seems exceedingly low, or if you look at prostatectomy that has a series of them, and this number seems exceedingly high. Please let us know about that information. So then how we think through this, so again, identify what the targeted procedure is. Is this an initiative that you already have at your institution? Is this something that's done commonly? However, your institution decides to identify and prioritize that. But then identifying the patients who underwent that procedure using the CPT code, and then identifying the patients who received, again, an electronically generated C2 opioid prescription after the procedure. So, excluding tramadol, codeine, buprenorphine, and so forth. And then of those patients whose total day supply was, you can either say 4 or more days or 3 or less days, but what we're trying to get to at the end are the patients who are prescribed 3 or less days. So again, the higher the number, the better here. 3 or less days of a C2 opioid at or after procedural discharge for those 7 procedures. Okay. So the next slide is the question slide, but I'm going to stop here. So what questions or comments do folks have as it pertains to this metric? And people have been really good about kind of putting questions in the chat box as we go. So I don't see anything popping up right now. 4B is very similar to 4A. It's just 0 days instead of 3. So seeing that I don't see anything popping up here, I'll skip through to 4B. But if you have questions about either of these or anything up to this point, really, please put that in the chat box. List of Schedule II opioids. Sure. Yeah. Well, I won't run through it all right now, but we'll make available to all the institutions. Here's a list of the drugs that we're including, and we'll think through the best way to do that. Whether that's at minimum, I think we can look through generic, generic products, and say fentanyl, yes, oxycodone, yes, hydrocodone, yes. Something more elaborate to the ICD or not ICD, sorry, NDC or something similar, maybe a little bit tougher, especially to keep updated. But certainly generic drug names is something that would be very easy there. So 4B, we're looking at the same as, yes, if your institution does less than 3 of the combined procedures between 4A and 4B, then you would report on, if you do 2 of them, then you can report on 2. If you only do 1, then you'd report on 1. If you don't do any procedures that would be listed at your institution, then you would have nothing to report for this. So now if you do the procedures at your institution and just didn't happen to do any that month, so January you did some, February you did some, March you didn't. Since you are reporting numerator and denominator, I would imagine that you're going to report a 0 and a 0 of nobody out of the nobody that we did this month. But if this is something that's never done at all at your institution, then you would not report. We have not discussed volume.
Doug, I think we need to clarify.
Sorry.
But,
go ahead.
Sorry, Doug. I think we need to clarify. I think Debbie's question was, if they do less than 3 procedures for the reporting period, so within the month, do they report them? And what you're saying is pick 3 procedures, and you'll report those each month, those procedures that you actually do within your organization, correct?
That's correct. What we haven't discussed are any kind of volume thresholds of if you only did 1 procedure, then would you report 0 of 1 or 1 out of 1, or do we need to have a minimum threshold before folks report anything? I don't have a thought or answer to that offhand. I don't know, Melanie, if you have thoughts or comments or historically what you guys have done. But I don't have an answer to that offhand.
I think think we can take that back to the advisory committee and ask if they would like to set up a threshold. In our other quality reporting initiatives that we've done, there has not been a threshold set. It's either they have done the procedures, they've not done the procedures, and if they've not done the procedures, obviously it's not applicable to their hospital. But we can certainly take that back to the advisory committee meeting next week and ask them, should we set a threshold?
Okay. And then as far as how the 3-day supply would be calculated, so there's kind of two things within this. So I'm not sure about all EMRs. I know ours has an option to put in day supply. It's not a requirement. So within the prescription that's generated, so you write a prescription for oxycodone, whatever, it'll say, day supply. And so the day supply is a field in some. So one option is mandating that field if that's possible within your EMR. What we have also done is looked at the directions within the prescription and assigned the daily quantity or the daily number of units. So if it's 1 every 6 hours, well, that's 4. And the quantity prescribed, the number of pills, is always mandatory on a C2 prescription. So you have the directions, so you know that each day they take 4 pills. And using the same methodology that Casper does of, the Casper looks through what the pharmacy administers, but this is supposed to be done using, they take as many as they could that day. So every 4 to 6 hours means every 4 hours. 1 to 2 every 4 to 6 hours means 2 every 4 hours, right? So as many as they could take in a given day as prescribed, and say that we know they take this many per day. This is how many units they were written. We divide one by the other, and that tells us the number of days that this will last. And then, a rate of 0% for someone that only did 1 procedure doesn't matter from a PI standpoint. Yeah, and I think these kind of comments, I think that makes sense. Is the stuff that we'll take to the advisory meeting. I think it may also be worth, we can kind of elaborate a little more in writing of a suggested methodology for how you calculate day supply and kind of, basically write down in a cleaner fashion what I went through just there, so that we're all trying to do day supply the same way. To address that question. Okay. So this is 0 days. So basically people who didn't get an opioid within 4B, and what we're looking at here are cardiac catheterizations, dental extractions, and uncomplicated vaginal deliveries. What I can already tell you is that we've identified that that specifically the ICD for vaginal delivery is not capturing, does not appear to be capturing everything. So we're trying to figure out how else these are identified in our system. So if you all identify the same kinds of things, again, please let us know. Methodology being the same here as it was for 4A. So identify if you're targeting a procedure from this list. Remember, it's really 3 between the 2, ideally all of them, but 3 between 4A and 4B. And then identify patients who received any electronically generated C2 prescription after that procedure. And what you're looking at are the percent of patients that received nothing. And I think the same comments of a threshold, a monthly threshold and stuff like that would apply to this metric the same as they would apply to 4A as we discussed that. Okay. Other questions, comments, anything within I don't see anything within the chat box, and we've still got a little bit of stuff to go through. This is the last of the metrics that we're digging into in any depth here. Okay. All right, I'll keep an eye on that as Melanie goes through the rest of this, if there are other questions and stuff that come up. But Melanie, I'll go ahead and turn this back over to you at this point.
Great, thank you, Doug. We really appreciate that. What I'm going to cover this morning is how we are actually going to report both the process structural measures and the outcome measures. Some of you may be familiar with our Kentucky Quality Counts data collection reporting system with other initiatives that you're doing currently with KHA, maybe the HEN work or other initiatives that we're doing. If you're not, we're going to get you familiar with it because this will be the one-stop reporting place that we will do all reporting for Kentucky SOS. It's a web-based secure portal that you will log in with your email address and your password once we set you up. Our plan is to give access to the primary contact person for the Kentucky SOS. However, that doesn't mean that other people can't have access. So you at your organization, there will be one or more persons available to have access to the Kentucky Quality Counts data reporting collection system. Not only will you do the data collection or the data entry here, but there are also reports that will be available to your facility. So after the webinar, we will begin setting up the primary lead for the Kentucky SOS access to Kentucky Quality Counts. If by chance you already have access, you will not get a second username and password. What you will be able to do is click on the initiative if you're in multiple initiatives with KHA, and you'll be able to access Kentucky SOS. So if you currently have access, you will not get a new username and password. You will use your current, but you will see a drop-down to choose the initiative, whether it's HEN or Kentucky SOS. Again, this platform is web-based, so at any point in time, people can access it throughout the day, weekends, whenever it is convenient for adding in that data. As I said, this is where we will add in all of the data, whether it's a process structural measure or the outcome measures that Deb just went through. Now, some people have asked, what's going to be our baseline period? We're not going to ask that you go back. What we are going to do for baseline is we're going to take the first 3 months of the outcome data, which will be January through March of 2020. So we're not going to ask that you go back into 2019 and provide a baseline period. We did not want to do that data burden if you weren't already capturing this information. So each month, the data lead or the contact person will come into Kentucky Quality Counts and add in the outcome and the process measures. They're going to come to a screen that looks exactly like this. It's going to have 2 options, data entry, reports, and then there's a section for alerts. So if you are behind on your outcome measurements or your process measurements, you'll see an alert here that you may be missing a month or several months. So again, we try to keep you up to date. The system will automatically generate an email reminding the person who has access to this that the data is coming due. And the data is going to be due 30 days after the month. So January data will be due by the end of February. So when you come to your screen and log in, again, you're going to see the 2 options. So when you click on data entry, you'll then come to the next option. So if you are a person who has multiple hospitals that you're responsible for, and I use this example just so that you can see. Obviously, if you have access for only your hospital, you're just going to have your hospital available. I'm going to use TJ Health as an example here. This person may have access to both TJ Health Columbia and TJ Sampson Community Hospital. So they'll be able to choose and filter between both hospitals to be able to input the data so they're not logging in and logging out. Also over here, you'll see a period drop-down where you will get to choose what month you are actually inputting the data for. When you choose the period, it will then come to the next screen where you'll see the metric and then you'll see the numerator and denominator. This is where you will manually enter in the numerator and your denominator. The blue icons that have an eye are your description of what that numerator is and what that denominator is. You'll save that each time. Now, if you don't have all your data at once, you can come in and out of the system, enter in the metric that you would like, and then hit save. There's also a feature that it shows a timing. So if you're in there and get distracted, there's going to be a time that allows you before the system will automatically log you out. So what I always say to people is save often. So if you're in there, we all get distracted by phone calls or someone coming into our office. As soon as you put a data point in there, save it. So once you enter a numerator, denominator, go ahead and hit save. For those process measures, or let me go back to 4. So what you saw here was 2A, 2B, 3A, B, and C. Now for 4A and 4B, those are based on the procedures that you are going to choose that your facility will be reporting on. We will need you to tell Emily and I which procedures you plan to do. The requirement is at least 3 if they're applicable, or you can report up to all 10. Now for our specialty hospitals, for those of you who don't do procedures at your hospitals, obviously these metrics will not appear in Kentucky Quality Count. If you don't have an ER, those metrics will not appear in Kentucky Quality Count for you. You will only see the process and the outcome measures that do apply to your specific hospital. And on 4A and 4B, we will need for you to tell us specifically what metrics you plan to do as far as which procedures you're planning to report on. If you get into the project and you decide that you want to do more, say you limit it to 3 and then you decide 2-3 months from now you want to add more. At any point in time, we can add those metrics in and you can start reporting. So we want to be as flexible as possible, and again, you'll only see those that really apply to you. For the process measures or structural measures, these are going to be a yes, no. And those are the ones, the 5 listed here, that are really just a yes, no. Is your facility doing this? So number 1, safe opioid prescribing is an organizational priority. Everyone has a yes for that because you signed on to the Kentucky SOS project. You're going to answer that question one time, and then yes is going to appear every month after that. So unless something changes, you most likely, if you've answered yes to every one of these on 1 month, you will not have to change those. The only time you will have to change those is if you answered no to one of them, and then when you start doing it, you would go in and change that to a yes. So if your hospital is not doing community partnerships, the number 5, you haven't quite done that yet. You're going to answer no in the beginning, and then when you start doing that, you'll go into quality counts and change that at a yes at any month that you started actually doing that process measure. So again, we tried to make these as easy as possible to answer the yes, no. Some of these are already been answered on your needs assessment. So we'll be able to populate some of these. If you did not complete your needs assessment, we will need that before we set it up in quality count. And again, we can do that at any point in time. So I'm going to take any questions that might be about how we need to report. Again, I'm going to kind of backwards here. You will receive access once we have everything set up. Your primary lead for SOS will get the first point of access. If you want other folks within your organization to have access because they'll be entering the data, you will need to notify Emily Henderson or myself here at KHA so that we can set those up. So a question in the chat box, when will the deadline be for providing which procedures facilities will be doing? We would really like that before the end of January, Amy. So we're asking because we're going to have all this set up in quality counts. We would really like to know that information before the end of January. And I've got that on our next steps here. So you're going to contact Emily or myself for additional data contacts. We would like that also to be before the end of January. What procedures you plan to do for metric 4A and 4B by the end of January. And Emily will be sending out any facilities that have not completed their needs assessment before the end of January too. She'll send that out this week, and we'd like that back before the end of January. If we continue not to get it back, we will follow up with you consistently so that we have that information. What we're talking about doing on that needs assessment is doing it another time throughout the project. So again, if we need to update any information on that needs assessment. Other questions about Kentucky quality counts or reporting the metrics. I'm always available to do a one-on-one training for Kentucky quality counts. It's really a simple, user-friendly system. We have learned that through the HIN project and our other quality initiatives here, that it's very simple for people to get in and use. The reports that will be in there are going to be available to those that have access, but they're all printable. And what we're talking about is having some measure run charts, some comparison reports like we currently have for all of our other initiatives, where you can compare to like-sized hospitals or hospital types. So again, if you are a psych facility, a LTAC facility, a rehab hospital, we are only going to place the metrics and Kentucky quality counts that apply to your facility. We know that you typically do not have an ER, and we know that you don't do surgical procedures, so you will not see those metrics in quality counts. You'll see the process measures and then potentially metrics 2A and 2B. Other questions? One last thing that we would like to remind everyone of is the upcoming Alternatives to Opioids webinar series that Dr. Ryan Stanton will be doing. The first one will be started on January 29th from 11 a.m. to 12 p.m. Eastern Standard Time. Calendar invites have been sent out to project leads, just like this one was sent. And we ask that the project leads please feel free to forward to other providers in your facility. We will be offering continuing education credits for these webinars. So this is going to be January 29th will be the Alternatives to Opioids Part 1. February 19th will be Part 2. And then March 25th will be Part 3. All of those are at the same time, 11 a.m. to 12 p.m. Eastern Standard Time. Again, those calendar invites have been sent out. If you did not receive one and would like one, please contact Emily Henderson. She will make sure to get that to you. Also, be communicating with your project lead. If you are not the project lead and on this call, please make sure you know who your project lead is, because we are sending a lot of information to those leads. However, if you need to be added to our communication list, please let us know. We'll be more than happy to add you to the communication list so that you're getting all communications sent out. Again, here's Emily's contact information and my contact information. We will forward any questions that you may have for Doug or any of our advisory committee. So please send us the questions and we will forward those on. Again, today's webinar and the EOM will be available on our website. And we are also going to send out an email to all the project leads, a copy of today's presentation and a copy of the EOM. I'm going to open the lines up now for any final questions that we may have, and you can also type in the chat.
Presentation mode is now disabled.
So all lines are now open. If you had muted yourself, please feel free to hit *6 or unmute on your phone. Do we have any final questions or thoughts? Okay, great. If you think of things after today, please feel free to give us a call. Doug, we would like to thank you for all the work that you did on presenting today on our data metrics. I'm sure questions will come up as you get started on this. Please do not hesitate to reach out to us. We appreciate everybody being on the call today. Thank you all and have a great rest.